To start with, I'm Dr. Kosmas. I have the honor and the privilege to be the presenter of all the Live in a Box cases. I would like to thank Dr. Iacobu for the kind invitation. I hope to really enjoy the session. Before I start, I would like to thank all the Cath Lab staff for the love, the contribution, the support. Without them, I think nothing will be done. So, we have both operators here, Dr. Iacobu and Dr. Leodiadis. Please feel free to interrupt me whenever you want to make a comment. To start with, the first case is a case about how to investigate ostial left main disease and provide therapeutic solutions. It's about a male, 77-year-old, with severe MR, so he underwent a coronary angiogram with a short 90% left main and a right coronary artery with a 100% ostial closure. So about the medical history, shortness of breath, NYHA3, arterial hypertension, dyslipidemia, diabetes, smoker. So our plan was to investigate with IVUS and FFR the left main. So here is the case. The video.
So this is a patient that was referred to us by the surgical department.
Okay.
But there was a nodular lesion found in the city.
Also, what's the dominant reason of that referral from the surgical department?
So
what's the main reason? Too unstable.
The patient was really stable. He was very frail.
Frail.
Okay.
He was very frail. Had occluded, right?
So it was frailty. The main reason was frailty, non-cardiac reason.
So he was about to do a bypass surgery along with mitral valve procedures.
Okay, understood. Mainly frailty. Very good. Feel free to fast forward the video a little bit, okay? So we save some time.
Okay. So, Ilya, can you describe what we're doing? We have 3 wires there.
Ωραία. Αρχίζουμε λοιπόν automatic pullback από εκεί σε LAD. Ματίνα, βάλε λίγο ένα bookmark εκεί. Ωραία, υπάρχει έκεντρη πλάκα.
Eccentric back.
Στο στέλεχος πάμε. Στις 2 σύρματα. Ακόμα ένα bookmark. Και εδώ είμαστε στην αορτή, Τι λες?
Ηλία, fast forward a little bit.
Ναι, πολύ βραχή. Ωραία, για να το δούμε. Μπορείς να μας δεις λίγο αυτό κράτησε εδώ αυτό, 6,8. Το ενεγγύη σε LAD, λοιπόν. Ωραία. Προχώρα λίγο πιο...
So, Goran, we have an MLA of 6.86
είναι 6,18.
at the ostium of the left main. So, what appears to be a geographically very significant, maybe it's a slit-like stenosis.
But a lot of plaque, gigantic. There's
a lot of plaque burden, but you have a
huge. The vessel is 5 millimeters.
6.86 to 7 square millimeters. And what we can also see is that we have a reverse tapering. So the EMCSA at the ostium, at the proximal part of the left main, is smaller compared to the distal part of the left main. So it's one of these patients that have this slit-like, maybe not significant stenosis, but with a large plaque burden. So, George, what your approach would be in this case?
Well, I think this looks to be, first of all, and geographically highly significant. I didn't see very well, maybe it wasn't engaged or something, but the distal left main is preserved. So if we need to treat something, I'd like to stay short of the distal left main, make the procedure very simple in a frail patient.
Έχει μια slit-like στένωση, λοιπόν, η οποία τη μετράμε πάνω από 6, αλλά έχει σίγουρα reverse tapering, βλέπετε media.
The patient was stable all this time. The procedures.
The patient is really stable. That's why we didn't use any balloon pump or anything. No. So in addition, he has occluded right coronary artery, just to remind you.
Interesting that the patient has only that lesion. I don't see many other lesions anywhere else, which is interesting.
Goran, I don't know, what's your opinion on how to approach this patient that they have reverse tapering? So do you need to, of course, we need still to show that this is hemodynamically significant, right?
So in this gray zone, 6 point something with a geographically really tight lesion, guidelines suggest to use also physiology to confirm significance or exclude. Small limitation of physiology is that with occluded right, you have much larger territory actually that left coronary
exactly, and that's what we did. We have an RFR of 0.99 and we did an FFR as well. It was more than 0.94.
And if you have dilemma, actually physiology should be more relevant than mechanical imaging evaluation of the cross-sectional area.
So any other comments? Nico, would you treat this patient, George?
For me, it's very difficult to use FFR for the assessment of this lesion. I prefer IVUS, actually.
George, would you still operate to this patient? We saw that this measurement is pretty accurate. We did FFR, we did the equalizing of the FFR in the aorta. So we are pretty sure that this is not significant. That's why we didn't treat it. So would you, based on this information, still it looks like significant, but from one point. But would you still treat it?
Well, listen, it wasn't, the angiographic picture wasn't very good. So it was kind of, because the lesion is proximal, the guide was out. I got an impression it was tighter than perhaps it is. Perhaps a better picture might be more convincing angiographically, but you know, it's either you defer or you put an ostial stent, but it's not a complex bifurcational stent case for sure, which is a good thing for the patient. And I don't know the characteristics of the plaque also. If somehow the plaque is very fatty and unstable, that's another situation.
It's a long eccentric plaque extending to the proximal lady.
I was wondering how frequently it is for you that you do all these angios to have clear coronaries and just have disease simply at the ostia. I mean, my mind would say, without seeing any pictures, that maybe there is a significant disease of the aorta itself. I don't know how frequently you see that, to have clear distal coronaries, but here, I mean, obviously I couldn't see, I don't know if we had a CT scan, but from what we saw here, we couldn't see any significant atheromatosis of the aorta. But on the other hand, if you want to operate is the most easy thing. You can operate. As Professor Kokkinos said, I don't know how symptomatic this patient was.
That was going to be my question.
He was not. He was about to undergo a biopsy in the lung.
So probably I would go with Professor Kokkinos.
Well, I mean, let me just say for the Zoom audience, to internet audience, that the patient was due for a lung biopsy, non-cardiac procedure. So obviously the decision is simple. You just stop. If you want to defer, you don't put the patient on Plavix, you go ahead with a biopsy. And again, even tight lesions can wait. And obviously this intermediate lesion, if you can consider it later, and you can see perhaps to ultimately the decision here would be whether you do nothing or you put an ostial single left main stent away from a bifurcation of the simplest procedures, and this can be deferred after the lung biopsy. But to figure out that part as well. Perhaps you can even defer it for perhaps after consideration of mitral clip or something else. You want to conclude the case and go to the next one so we can still meet in 10 minutes. We're going to break.
Elliot wanted to say something.
Yes. So how do you suggest
Well, you're welcome to do a nuclear. You can do a nuclear if you want. After the biopsy, just do a nuclear and see what happens. Nuclear is still a possibility. So? Well, not really. Not really. Let's see. Maybe you have severe hypotension.
So, look, I think I completely agree with the treatment strategy here. We're all looking at left main stem, 90% stenosis. That is not true. The intravascular imaging isn't lying to us. It's absolutely definitive that at most it's moderate, it's not severe. The physiology says it's not severe. We've got two things available to us, feel better or live longer. And this patient has got COPD, a blocked right coronary artery, and severe MR. So they are not going to feel better. It will not be transformational for them. We cannot offer live longer with an ostial stent. We won't make anything safer. We'll make it higher risk. I think it shows the advantage of intracoronary imaging and intravascular physiology to support the treatment for this patient, which is a pair of slippers, a comfortable chair, a dog with very short legs, and chill out. And maybe one day come back to the mitral valve. Maybe that could make them feel better, but it won't make them live longer.
Very good. Ilya, go ahead.
Okay, so
talking about a controversial first case, medical therapy, exactly what Professor Kokkinos was talking about. Ultimately, the patient's well-being is dependent on the inflammation, the insulin resistance, the lipids, the MR, the CHF treatments, the medication compliance, absence of smoking. He has lung cancer for smoking, obviously, this patient. So, you know, a lot of situations.
So maybe this is a molecular solution.
There you go. Molecular. We refer him to molecular cardiology. That's part of the heart team. That's a message for the internet audience that we have.
Okay, so let's proceed to the second Live in a Box case. As we have the privilege to have here Professor Stankovic, we will talk about how to approach and treat ostial bifurcation lesions. Here our plan is to perform intravascular imaging guided stenting. So the case is about a male, 67-year-old with chest pain, 4 minutes duration, elevated troponin, non-STEMI, with preserved ejection fraction. About his coronary angiogram, the left main was without significant stenosis, but he has an osteoproximal significant stenosis in the left anterior descending artery. So CABG was proposed as first option. The patient refused and was transferred to our center. Our plan is here to perform intravascular imaging guided stenting. So here is his ECG in admission. So we continue to the video.
Το περιστατικό φοράζεται είναι 68 ετών, ο οποίος νοσηλεύτηκε με οξύ στεφανείο σύνδρομο σε άλλο νοσοκομείο. Έχει έρθει στο νοσοκομείο μας για περαιτέρω διερεύνηση και αντιμετώπιση. Η μία σύσταση είναι να γίνει καρδιοχειρουργική αντιμετώπιση. Όλοι συμφωνούμε ότι είναι κατάλληλος υποψήφιος, ωστόσο ο ασθενής προτιμάει την διαθερμική επαναγγείωση και όπως σε όλες αυτές τις περιπτώσεις, ο στόχος μας είναι να δούμε το είδος της αθερωματικής πλάκας, αν επεκτείνεται στο στέλεχος, γεωγραφικά φαίνεται πως επεκτείνεται, να μετρήσουμε το μέγεθος του αγκίου, τόσο του στελέχους όσο του προστίου κατιοντοκλάτους, αν εμπλέκεται και η περισπόμενη αρτηρία, και από εκεί πέρα να προχωρήσουμε στην κατάλληλη θεραπευτική αντιμετώπιση. Είναι μαζί μου ο Βαγγέλης Ολυντιάδης και η Ελένη Ηλιάδου, η Ματίνα, ο Διονύσης και ο Κώστας. Οπότε ο Ηλίας ο Κοσμάς θα μας πει περαιτέρω πληροφορίες από το ιστορικό, το άποτμα του στελέχου, πρώτος διαγώνιος κλάδος, ο οποίος διχάζεται και δίνει και ένα δεύτερο διαγώνιο κλάδο. Πήγαινε 40 δεξιά και λίγο κράνια. Θα δούμε λίγο την εγκύτητα. Και να πάμε και μια δεξιά κόντρα. Πήραμε. Κάνατε κάτι.
So it's a 0-0-1 bifurcation. Very interesting. The bifurcation at least. What happened in the ostium, that's another part. But...
Ωραία.
Let's see.
Can I comment?
Yes.
So it's 0-1-0, and I was afraid that you will show ostial circ. For ostial circ, we really don't have good solution, and there are multiple different strategies. But for ostial LAD, which is even angiographically projecting from the distal left main into the ostium of the LAD, we know from Oviedo and circulation paper in 2010 that 95% of isolated ostial LAD, it's actually diffuse disease from the left main into the LAD. Image guided, of course, as a strategy, but always crossover. Very difficult to be precise unless by imaging you completely exclude presence of plaque inside the left main. You can use precise stenting if you have IVUS positioned at the ostium of the circ, and by positioning IVUS probe exactly at the carina level, you can try to precisely position stent. But in my view, and really several hundred of similar cases that I reviewed in 25 years, I believe that it's much more predictable, it's much more straightforward to crossover stent from the left main, optimize stent expansion inside the left main. You don't have disease in the circ, no need to do kissing. So crossover stenting, IVUS guided mainly to determine distal landing zone. As you mentioned, there is also ostial diagonal, short, and plaque extending to diagonal lesions. So if you want to decide where to stop your stent, actually you need imaging. In my view, it looks again that you stent from distally from the diagonal and then all the way into the left main.
Into the left main.
Inside the left main.
To the pod and
inside the left main, you need to have 6 to 8 millimeters of metal, just enough to perform proximal.
That's why we present this case. I think it's we need to discuss case, but we did the IVUS. We thought that we had the left main involvement, but it was not there. And we have a big discrepancy, large discrepancy between the media to media from LAD to left main. So, as you can see here, when the IVUS goes back, the pullback goes to the left main, we don't see any significant disease, and we have actually a step down from the LAD lesion to the left main. So we decided that the left main lesion was, the left main was spared. That's why we pre-dilated, we did the IVUS, and Ilya, you can, we felt confident that we can get away with one stent at the ostium of the LAD.
What's your opinion about using of DCB in this patient? It's a 001.
Yeah, intuitively it's wonderful. But if you look the evidence, absolutely no evidence supporting this use. Yeah. So we need to collect some evidence and make sure that we really do a benefit. For isolated ostial circ, again, maybe we can consider, but in order to deliver drug with DCB, it's just like painting, so you need to extensively pre-dilate, dissect the plaque, and then just deliver drug in the vessel wall. Intuitively, maybe it will work, but to leave dissected ostial LAD, I don't think it's a common practice. So in this case, definitely stenting.
I thought he was talking about DCB in the ostial circ. If you protect it, that's what he meant, not in the proximal LAD. Let's not be too crazy about that. No, proximal LAD is a classical stent case. Let me make it a little controversial. Goran thinks that always go to left main. I very large in the distal. And there is a little plaque here. I think Yannis IVUS is very telling because there was minimal plaque in left main. But of course, it's the interventional part. Can you see and can you really nail the ostium?
The LADs stand.
We can see at the bottom left now the IVUS, very good.
Some reason it was
you see how circular the stent is. That is excellent expansion.
George,
and you can see as we go to the left main.
I was never able to be precise. I either floated with stent inside the left main or I missed the ostium of the left main. So I decided to crossover stent, do the pot. There is no large plaque inside the left main.
Right,
adequately sized pot balloon, small pressure just to expand the stent, and then have good clinical outcomes. We published in JACC Interventions 2 cases.
I think that this
one with floating struts that we had to convert to culotte because patient came back with acute coronary syndrome. The other one, we also tried ostial circ, again floating, created lesion at the ostium of the LAD. We had to convert to crush. So with all those experiences, the patient come back with acute coronary syndrome because floating metal at the divider of flow creates turbulence and increases neointimal proliferation and plaque formation. That's the only reason. I don't have data. This year, I suggested to focus EBC Club on isolated ostial circ treatment. And then we will write consensus how to do it with the available evidence. So far, I believe crossover stenting in both ways is the safest and the most predictable technical strategy.
Yes, we crossover the stent in the left main.
Yes.
Do you prefer to cover the ostium of the left main or in the middle?
No, depends. You know, in this case, it's clearly a long left main, no disease. So you just go 8 millimeters, 7, 8 millimeters, which is sufficient to do pot.
Yes.
Because you don't want to be short.
Pot.
Only for pot.
Yes, yes.
Nothing else.
All right, excellent. By the IVUS here, they showed that there was no strut in the left main. They covered the ostium perfectly. Is the end of the case. Final comment, Dr. Iakovou and Dr. Manginas right after. Welcome, Naso.
Also, we did the IVUS from the circumflex to the left main, and we didn't see any strut protrusion.
100%.
No malposition.
In two
so
dimensions.
Maybe we were lucky in this situation, you know, but
better lucky than good, we say sometimes.
Exactly. So
Naso, get the microphone though for the final comment, and thank you very much, Ilia Kozma. Excellent presentation. We are going to go on break in 1 minute after this.